Welcome to the deep dive. Okay, so today we're really focusing in squarely on two names you hear everywhere in weight management, Wegovy and Mounjaro.
That's semaglutide and tirzepatide, chemically speaking.
Right. We've looked through the research you sent over, and the goal here is to, cut through the noise and get straight to the key differences.
It's definitely a necessary deep dive. Because these aren't, well, they're not just another diet pill. The kind of results we're seeing.
Yeah.
The average weight loss percentages, they're getting into territory previously only really seen with things like gastric bypass surgery.
That's a huge statement.
Mm-hmm.
And the difference between these two specifically seems pretty stark right from the start, doesn't it? The data shows Wegovy users hitting about, 15% average body weight loss?
Typically, yes. Around 15%.
But then Mounjaro seems to push that quite a bit further, often closer to 20% loss?
That's right, closer to 20% on average. And that 5% difference, statistically speaking, it's significant. It really comes down to the underlying chemistry.
We'll definitely get into that. But first, I thought that story behind the Mounjaro name was fascinating. You pointed that out.
Oh, the Kilimanjaro connection.
Yeah.
Yes.
It comes from Mount Kilimanjaro. Highest peak in Africa, but crucially, one you can actually climb just by walking. You don't need, technical gear.
It's a great metaphor, isn't it?
Yeah.
It suggests this major goal, losing significant weight, it's a huge challenge, like climbing a mountain.
But it's achievable. It's within reach for, the average person using this tool. Not easy, but doable.
Exactly. It frames the medication as this powerful aid for a tough but ultimately accessible summit.
Okay, let's unpack this. So fundamentally, both these drugs, they start in the same place, right? This term GLP-1 keeps coming up. How does that actually work?
Right. So GLP-1, that stands for glucagon-like peptide 1. And the interesting thing is it's a natural peptide. Your body already makes it.
Oh, okay. So the drug isn't introducing something totally alien.
Not entirely. These medications are basically synthetic versions or analogs. They act like a booster or a longer-lasting replacement for your own GLP-1 signal.
So why does the synthetic version have such a powerful effect if our body already produces it?
It's engineered to be more potent and to stick around much longer than the natural version your body makes, which degrades quite quickly. So once you inject it, it travels up to the hypothalamus in your brain. That's sort of the master control center for appetite and metabolism.
Got it. Control center.
And it sends a signal down to your stomach.
And what does that signal do, practically speaking?
It essentially tells the stomach to slow down.
Mm-hmm.
The key mechanism is delaying gastric emptying.
Okay, so slowing down digestion.
Precisely. So normally you eat a meal and your stomach empties out in maybe about 4 hours, give or take.
Right.
With the GLP-1 drugs, the research indicates the stomach can stay, puffed up or full for much longer, maybe 8 to 9 hours.
9 hours. Wow, that's a massive change physiologically, from 4 hours to 9.
It is. And you can see how that impacts eating, right? If you eat breakfast at 8 a.m.
By lunchtime, noon, or 1 p.m., your stomach's still pretty full from breakfast.
Exactly. So you're naturally less hungry, you eat less at that next meal, and therefore consume fewer calories overall.
Does that prolonged fullness cause, discomfort beyond just not being hungry?
It certainly can, and that leads directly into the side effects we need to talk about. But the primary action is that appetite suppression. Oh, and just quickly on administration, it's an injection pen. You use it subcutaneously, so just under the skin. Usually in the abdomen, sort of a hand's width away from the belly button is often recommended.
Okay, so that delayed emptying, that GLP-1 effect, that explains the roughly 15% weight loss we see with Wegovy. But that brings us back to Mounjaro's extra 5%. Here's where it gets really interesting. What's Mounjaro doing differently?
Right, this is the core difference. Wegovy, or semaglutide, is what we call a single-action agonist. It only targets that GLP-1 receptor.
So its main job is just that fullness, that appetite control.
Primarily, yes.
Which suggests it might hit a kind of performance ceiling that Mounjaro bypasses.
That's the idea. Mounjaro, or tirzepatide, is a dual-action agonist. It hits the GLP-1 receptor, just like Wegovy.
Okay.
Plus, it also activates another receptor called GIP, that's glucose-dependent insulinotropic polypeptide.
GIP. Okay, so GLP-1 handles the appetite. What does adding GIP bring to the table? Why does that push the weight loss higher?
GIP seems to play a really significant role in improving how the body handles fat. It helps shift the body's energy preference. Meaning, instead of relying mainly on carbohydrates or starch for fuel, activating GIP encourages the body to burn its stored fat more effectively.
Ah, I see. So you get the eat less effect from GLP-1 and burn fat better effect from GIP.
That's a good way to put it. You get that combined effect the appetite suppression plus the enhanced fat metabolism. And that combination appears to be why Mounjaro generally shows superior weight loss results in the studies.
That makes a lot of sense in explaining the efficacy gap. But okay, let's shift to the practical side for someone considering the dosing protocol. The sources are really clear that you have to titrate up slowly. Why is that so critical?
It's purely about managing side effects, tolerability. The final dose, the one that gives the best weight loss results, is quite high. If you started there, well, you couldn't.
So you have to start really low.
Extremely low. And you adjust timing usually every 7 days, but you only increase the actual dose size maybe every 4 weeks, so once a month. It's a gradual ramp up.
What would happen if someone, say, got impatient, maybe found a higher dose pen online somehow, and just jumped to the top dose?
Oh, they'd be incredibly sick, just violently ill. We're talking severe nausea, constant vomiting, probably really intense and painful constipation, just completely unable to function.
So the body needs time to adapt to that slowdown effect.
Exactly. The slow titration lets your digestive system gradually get used to food staying around for much longer.
Which means the common side effects people do experience, even with titration, are basically the drug doing its job, maybe just a bit too strongly at first.
Yes, that's largely it. Things like bloating, gas, nausea, sometimes vomiting, constipation. These are all predictable consequences of delayed gastric emptying.
So if you experience those, it doesn't necessarily mean the drug is wrong for you.
Not necessarily. It's often a sign your body is adjusting. For many people, these side effects are most noticeable in the first few days after increasing a dose, and then they tend to settle down or disappear. Though some people do struggle more than others, of course.
The sources also mention something interesting beyond the physical stuff, psychological effects, like stress or irritability.
Yes, and that's a really important point that sometimes gets missed. Think about it. Eating is often deeply tied to routine, comfort, social interaction.
Yeah.
If suddenly your body is biologically telling you no to food much of the time, it can disrupt those ingrained habits and coping mechanisms. That can definitely cause mental strain or irritability for some people. Having support, medical and even emotional, is pretty key.
Absolutely. Now, who are these drugs actually intended for? What are the official criteria?
The main guideline revolves around body mass index, or BMI. Generally, if your BMI is over 30, you meet the primary criteria.
Okay, BMI over 30.
Then there's a secondary group. If your BMI is over 27, but you also have related health conditions, comorbidities like, say, heart disease, type 2 diabetes, or significant sleep apnea.
Got it. So 30 plus weight or 27 plus with other weight-related issues. What about someone who doesn't quite fit that? Maybe someone with a BMI of, I don't know, 24 or 25, just looking to lose a smaller amount of weight.
Well, according to the standard guidelines outlined in the sources, those individuals aren't typically the indicated population. If someone in that category wanted to explore it, it would need a very careful discussion with their doctor, understanding they fall outside those main criteria.
Right. Okay, let's talk warnings, contraindications. What are the absolute red flags? Who should definitely not take these?
The biggest ones relate to the thyroid. Anyone with a personal history of a specific type of thyroid cancer called medullary thyroid carcinoma, or MTC,
Okay.
or anyone who has a condition called multiple endocrine neoplasia syndrome type 2, or MNN2. Also, current thyroid nodules need careful evaluation. And if you have a strong family history of MTC, that also requires extreme caution and a thorough doctor consultation.
So thyroid history is a major checkpoint. What else?
Well, allergy is always a possibility with any drug. An allergy to semaglutide, tirzepatide, or any of the other ingredients in the injection.
Which is another reason for starting low, presumably,
Yeah.
to test for reactions.
Exactly. It helps manage digestive side effects. A&D serves as a safety check for allergies. Beyond that, extreme caution is needed for people with certain pre-existing conditions. Kidney failure, a history of pancreatitis.
Pancreatitis, okay.
Significant existing intestinal problems, maybe severe gastroparesis already. Also, active eating disorders or severe pre-existing psychological distress around food might make these drugs unsuitable.
And a really crucial one, pregnancy.
Absolutely non-negotiable.
Yeah.
The safety during pregnancy just hasn't been established. So women who are pregnant or even planning to conceive soon should avoid these medications entirely.
Okay. This raises an important question. A big concern you hear is the yo-yo effect. People worry that as soon as they stop the medication, all the weight just comes flooding back. Is that a major risk here?
It's a very real risk, yes. But the key thing is, it's often preventable if the weight loss is managed correctly.
How so? What goes wrong?
The problem often arises when someone focuses only on the scale dropping maybe crash dieting alongside the drug, and crucially, not getting enough protein.
Why is protein intake so critical?
Because if you're in a large calorie deficit without enough protein, your body doesn't just burn fat, it also breaks down significant amounts of muscle mass.
Right, losing muscle.
And muscle is metabolically active tissue. It burns calories even at rest. So if you lose a lot of muscle while losing weight, your baseline metabolism slows down considerably.
Ah, so when you stop the drug, your appetite comes back.
Your appetite returns, potentially quite strongly, but now your metabolic rate, your body's calorie-burning engine, is running much slower than before because you lost muscle. That's a recipe for rapid weight regain, sometimes even exceeding the starting point.
So the solution isn't just taking the drug, it's managing the type of weight loss.
Exactly. Proper medical supervision should ideally include monitoring body composition, tracking muscle mass versus fat mass, maybe using specific machines for that, and ensuring the patient meets adequate protein goals throughout the process is vital.
Which brings us to a crucial caveat, really. You mentioned this earlier. These drugs aren't magic bullets, are they?
Not at all. They are incredibly powerful tools, maybe the best we've ever had for medical weight management. But they only control one part of the equation, appetite, and in Mounjaro's case, partly metabolism.
They don't fix everything else.
Correct. They don't automatically improve your sleep, they don't force you to choose nutritious foods over processed ones, and they certainly don't make you exercise. Long-term success, and especially maintaining the loss after stopping the drug, still relies heavily on fundamental behavioral changes: healthy diet, hydration, movement. The drug just makes it physiologically easier to implement and stick to those changes.
That's a critical distinction. And finally, a serious warning from the sources about trying to get these medications outside of proper channels, like online, without a prescription.
Yes, this is incredibly dangerous. The sources warn it's surprisingly easy to find sites claiming to sell them, but the risks are huge.
What kind of risks?
Two main ones. First, you have absolutely no idea what you're actually getting. It could be fake, counterfeit, contaminated, underdosed, overdosed, potentially very harmful.
Yeah, that's scary.
Second, remember, obesity is recognized by the WHO and major medical bodies as a chronic disease. Trying to treat it yourself without a doctor means you bypass essential health checks. You might have underlying issues like high blood pressure, high cholesterol, prediabetes, or other metabolic problems that need diagnosis and management alongside the weight loss. Self-medicating just isn't safe. Always consult a qualified physician.
That's a vital message. So, wrapping this up, it seems like a tremendously insightful look. Mounjaro's dual GLP-1 and GIP action really seems to be its defining feature, giving it that statistical edge in weight loss.
It appears so, based on the current data.
But ultimately, even though both are highly effective, they're sophisticated tools, they absolutely require sticking to those medical protocols, the slow titration, monitoring body composition, especially muscle mass, and crucially, committing to those broader lifestyle changes for sustainable results and to avoid that rebound effect.
Precisely. The injection pen can silence the noise of constant hunger, which is a massive help. But you, the patient, still have to actively choose the right path, the right foods, the right habits for the long journey.
Well said. And maybe we can leave you, the listener, with a final thought to mull over. Given how powerfully activating that GIP receptor seems to shift metabolism towards fat burning, as we see with Mounjaro, what might future research look like focusing just on GIP? Could we see treatments aimed purely at improving metabolic health via GIP, maybe even for people who don't need dramatic weight loss?
That's a fascinating area. The idea of selectively tweaking these metabolic pathways. It's really changing how we think about internal medicine and metabolic diseases.
Definitely food for thought. Thanks for joining us for this deep dive.